Thank you very much for the introduction. So we'll go ahead and get started with the EE&T portion of this course. First up, disclosures. I have no disclosures or financial relationships to disclose. These are our objectives for this hour. To start off, I included some pictures for review of the eye. Here I have listed some anatomy and some functions associated with those structures. First up is foreign body. So subjectively, patients will experience pain, irritation, and a sense of foreign body in their eye. To examine this, you should avert the eyelid. You can stain with fluorescein and observe with a Woods lamp. If you see a foreign body, you can attempt removal with a moist cotton tip swab. If a foreign body is present, you can consider patching for corneal abrasions and assessing the next day. If there's penetrating trauma, you don't want to remove this. You want to send them over for emergency examination at the ED. If a chemical burn is present, you want to flush with saline for 30 minutes at minimum and refer them out to the emergency room or to an ophthalmologist. Next up is a blowout fracture. So this is a fracture of the orbital floor, which includes the maxillary, palatine, and zygomatic bones. This is typically from a blunt force trauma such as a ball or a fist. This can result in entrapment of the infraorbital nerve, which will result in paresthesia of the gums, upper lip, and cheeks. It can also result in entrapment of the inferior rectus muscle, so patients won't be able to lift their eye up on exam. The symptoms also can include swelling, pain, and reduced movement of the eye. You can also develop an ophthalmos where the eye is sunken in. A CT can be done to further evaluate this, and this is something that should be referred out. Surgery may be required. A globe rupture is an open globe injury that can include penetration, perforation, or laceration. It results in gross deformity of the eye. Patients will experience decreased visual acuity. On exam, they can have an eccentric or teardrop-shaped pupil. It can result in extrusion of the vitreous humor. You can get a prolapse of internal ocular structures. Management of this includes an eye shield, bed rest, avoiding oral intake, avoiding eye solutions, antiemetics to prevent vomiting, pain medications, and should be evaluated by an ophthalmologist. Scleritis is inflammation of the sclera resulting in erythema and pain that radiates to the face and periorbital region. Approximately half the time it's associated with a more systemic inflammatory condition. There's several different types, the most common being diffuse anterior scleritis. It counts for approximately 50% of the cases and typically responds to mild therapies and doesn't recur. There's also nodular anterior scleritis, accounting for approximately 20 to 40% of cases, and patients can experience multiple attacks of this. Lastly, and kind of the least common, is necrotizing anterior scleritis. It's more often seen in women. It's often associated with systemic illness and more likely to lead to ocular complications. To diagnose this, patients typically have eye pain with tenderness to palpation, and they can have significant erythema. Examination can be performed with slit lip and ophthalmoscopy. Tissue biopsy may be needed. All suspected cases of scleritis should be referred to ophthalmology, and treatments individualized based on the severity of disease and underlying condition. Treatment should be directed by an ophthalmologist or rheumatologist.